Hello, this is Dr. Who. I am going to present a case study on skin and soft tissue. This case study is about a 19-year-old student who presents to the urgent care with a new onset boil on his right buttock. The boil is secondary to sports-related trauma. He was seen at the Student Health Center where his wound was clean and he was given a prescription for clindamycin 300 milligram 4 times a day. He has a history of penicillin allergy. He was non-adherent to the clindamycin due to nausea and a 4 times a day schedule. About a week later, he returned to the Student Health Center and was ultimately sent to the urgent care for further evaluation and treatment of his continued skin and soft tissue infection. At the urgent care, he had the abscess area drained via incision and drainage and was sent home with wound care instructions only. Jimmy returned to the urgent care 8 days later with recurrent boil in the same area. He is afebrile. His temperature was 37.7 degrees Celsius. All vital signs are stable, and a second incision and drainage, which is IND, was performed. The fluid from the second IND was sent for culture and sensitivity. His nares and groin areas were swabbed for methicillin-resistant Staphylococcus aureus, MRSA, and blood cultures drawn, all of which are pending. The MRI of the gluteal area was negative for signs of deep tissue infection, and it was determined that the patient did not need to be admitted to the hospital. However, an antibiotic was warranted in this recurrent infection case. The patient was considered to have a purulent SSTI, with the most likely organism being Staphylococcus aureus and methicillin-resistant Staphylococcus aureus as the predominant pathogen on the first episode. Since the patient presented with a mild SSTI, an IND alone can be considered an appropriate treatment regimen. On recurrence, it is assumed that it is again Staphylococcus aureus and methicillin-resistant Staphylococcus aureus that was reintroduced into the wound from either improper hygiene or organism colonization of the skin. The wound was drained and all the appropriate cultures were drawn, and the clinical condition of the patient, which he was afebrile with no extension of the infection outside of the local area. So it's basically the clinical condition of the patient would now be considered a moderate infection and would still necessitate only outpatient treatment. However, an oral antibiotic should be recommended in addition to the IND for treatment and eradication of the organism. We can classify SSTI either as purulent or non-purulent, and these can be either mild, moderate, or severe. We're going to begin with purulent SSTI. Cutaneous abscesses are collection of pus in the dermal layer and beyond. Furuncles are infections surrounding the hair follicle in which pus can extend to the subcutaneous tissue and typically results in a relatively small abscess where a small abscess forms. Carbuncles are larger than furuncles in which a collection of adjacent hair follicles become infected and the tissue collections merge together to form a large abscess. Non-purulent SSTI are infections that do not have any associated pus. Cellulitis is a diffuse spreading infection of the dermis and beyond that is red, warm, and tender with no definitive border. Erysipelas is similar in presentation to cellulitis and is most associated with the face only, and it has a well demarcated border. Cellulitis and erysipelas are synonymous in some literature. Non-purulent SSTI can be mild, moderate, or severe. Mild will have the absence of systemic signs of infection. With the moderate, there is presence of the systemic signs of infection, but otherwise the patient would be clinically stable and will not meet the severe criteria. So severe purulent infection will have failed incision and drainage plus oral antibiotics or the presence of systemic signs of infection such as temperature being greater than 38 degrees Celsius, tachycardic greater than 90 beats per minute, tachypnea, the patient is going to have respiratory rate greater than 24 breaths per minute, or they're going to have the white blood cell counts that is abnormal, will be abnormally low, less than 4,000, or greater than 12,000, or the person is immunocompromised. Now, with the severe non-purulent infection, the person is going to have all of this, plus they're going to have deep tissue involvement as evidenced by bullae, skin sloughing, hypotension, or organ dysfunction. So these patients who have this condition will need hospitalization. The classification of Jimmy's cellulitis at this initial presentation to the Student Health Center was considered mild and no evidence of purulent present. When he returned to the Student Center the second time, he was referred to the urgent care due to the lack of response to oral clindamycin, which was due to his non-compliance and the development of a purulent infection that resulted in an IND. The severity of Jimmy's purulent SSTI was classified as mild with no true systemic manifestations. Jimmy complained of pain, irritation, and swelling in the right gluteal area secondary to a trauma. His right gluteal area was red, erythematous, warm, and tender to touch. Localized fluid collection consisted with a carbuncle and surrounding erythema. He has a low-grade temperature of 37.5 degrees Celsius, which is 99.5 degrees Fahrenheit. His white cell count, blood cell count, was 11,300. So slightly elevated, but does not meet the definition of a systemic sign of infection. The most common causative organisms for the purulent SSTI are methicillin-sensitive Staphylococcus aureus, MSSA, or MRSA, which is methicillin-resistant Staphylococcus aureus. For the non-purulent SSTI are Group A, beta hemolytic streptococci, which is the causing agent is Streptococcus pyogenes, and then you have the methicillin-sensitive S. aureus, MSSA, for moderate and severe infections. What are the goals of non-pharmacological treatment for this patient's SSTI? So you can do an IND, drain the abscess. The Infectious Disease Society of America guidelines for the treatment of skin and soft tissue infections and MRSA recommend IND for all purulent abscesses. MRSA infections are prevalent in patients who are otherwise healthy. These infections are usually purulent and should be drained if possible. Of note, MRSA lesions may present as a boil, cutaneous abscess, furuncle, or carbuncle that can be progressive and move from site to site. In such cases, surgical debridement is required for successful outcomes. You can also help reduce temperature, teach proper hand washing and wound care, focus on hygiene or environmental measures, encourage to take the full course of his antibiotic, restore patients' activity of daily living and attendance of classes. The spread of MRSA is common to athletes, other individuals who share common environments such as jails and military quarters, household contacts, intravenous drug users, and men who have sex with men. The most common method by which MRSA causes infection is via the skin. Therefore, breaks in the skin barrier, such as athlete's foot, are often the entry point for infection. The spread of MRSA is attributed to its colonization of the nares, but also its prevalence is non-nasal areas such as axilla, groin, and rectal areas. To aid its spread from person to person, MRSA is known to contaminate solid surfaces, towels, razors, and other commonly touched sites and objects. Taken together, these risk factors and exposures have made it relatively easy for MRSA to become an epidemic. To educate the public on the risk factors for MRSA, the 5 C's were created: contact, direct skin-to-skin contact; cleanliness, compromised skin integrity; contaminated objects, surfaces, and items; crowded living conditions. Measures to control each aspect of these risk factors are recommended for the prevention and spread of MRSA. For athletes, the following recommendations were made. Recommendations for athletes are first aid training, encourage good hygiene, hand washing after communal service contact and person-to-person contact, showering after activities, clean and cover all skin wounds, scrapes, and other injuries where the skin is not intact. Exclude athletes from activities while infectious wounds are open. Encourage athletes to report such injuries. Consider treating any cases of athlete's foot to reduce potential portals of entry. Do not share towels or personal items. Routinely clean mats, equipment, communal showers, baths, whirlpools, etc. Communal living conditions are an environment for spread. While these cannot be eliminated, better focus attention to the hygiene of the individuals and the environment can minimize risk for acquisition and or spread of infection. Empiric antibiotic selection for the mild purulent SSTIs, trimethoprim sulfamethoxazole 1 to 2 double strength tablets PO twice a day BID. Due to the limited clinical data with trimethoprim sulfamethoxazole in the treatment of streptococci, current guidelines suggest adding a beta-lactam to TMP SMX, that's trimethoprim sulfamethoxazole, when both streptococci and MRSA are suspected. However, in non-purulent infections, the beta-lactam alone would be sufficient. Doxycycline 100 mg PO BID, minocycline 100 mg PO BID, linezolid 600 mg PO BID, clindamycin 300 to 400 mg PO TID or QID. Doses greater than 450 TID are often not tolerated due to nausea and vomiting. And then the MRSA strains have demonstrated increasing resistance to clindamycin. So the geographical variations, you have to check that in your locality to make sure that there isn't a buildup of resistance of clindamycin in the region that you are located in. And then, of course, particularly in adults, there's about 50% resistance to clindamycin. In all cases, culture and susceptibility results should be followed up on, and antibiotic therapy should be tailored to these results. The most appropriate antibiotic therapy based upon culture and susceptibility results. So you basically want to narrow the spectrum of antibiotic to treat the organism with the correct antibiotic. We're going to continue with the empiric antibiotic selection for mild, non-purulent SSTIs. Penicillinase resistant penicillin or first generation cephalosporin can be used. Dicloxilin 500 mg PO QID, cephaloxin 500 mg PO TID or QID, cefadroxil 0.5 gram to 1 gram BID, and this can be used in place of cephaloxin. Both dicloxilin and cephaloxin have activities against the primary gram-positive pathogens such as group A streptococci caused by streptococci pyrogenes and the methicillin-sensitive Staphylococcus aureus. For mild, non-purulent SSTIs, dicloxilin is considered the first-line antimicrobial agent due to the robust amount of literature. However, cephaloxin regimens may be more conducive to promoting adherence and have been demonstrated to be effective. Now let's talk about some common shapes of the bacterial pathogens on this slide. So bacteria can be classified and named by their shapes and reaction to staining with crystal violet dye and oxygen requirements. The shapes under a microscope: a bacillus is a rod-shaped organism and cocci are spherical. When a cocci appear in clusters, they are called staphylococci. When they are arranged in chains, they are called streptococci. The cocci also can be found in duos called diplococci, such as those found in pairs like Neisseria gonorrhea. Staphylococcus aureus are gram-positive bacteria. These are part of our normal flora of the skin and upper airway, respiratory airway, and these are very common pathogens. Some people carry them in their inner nares. The bacteria are directly spread by direct contact with people who are infected or who are carriers. The hands of healthcare workers are considered a major source of indirect spread and hospital-acquired infections. The bacteria also survive on inanimate surfaces for a long periods of time. So Staphylococcus aureus can cause skin infections such as boils and carbuncles. When burns or surgical wounds become contaminated with S. aureus, they often produce endotoxins that destroy erythrocytes, leukocytes, platelets, and fibroblasts, and other human cells. These bacteria can also cause infections of the respiratory tract and urinary tract. Also, when many strains are ingested, they produce enterotoxins that cause food poisoning. The enterotoxins survive heating at temperatures high enough to kill the bacteria, so reheating food does not prevent food poisoning. High-risk groups for Staphylococcus infections include newborns, older adults, and people who are malnourished or obese or who have diabetes. In children, Staphylococcus infections of the respiratory tract are most common in those younger than 2 years of age. In adults, Staphylococcus pneumonia also uh, often occurs in uh, people with chronic lung disease or as a secondary bacterial infection after influenza. The influenza virus destroys the ciliated epithelium of the respiratory tract and thereby aids bacterial invasion. Certain streptococci are part of the normal microbial flora of the throat and nasopharynx in many healthy people. These gram-positive bacteria do not usually cause disease unless the mucosal bacteria is damaged by trauma, previous infection, or surgical manipulation. Such damage follows the bacteria to enter the bloodstream and gain access to other parts of the body where they colonize and then cause an infection. Streptococci pneumoniae bacteria, often called pneumococci, are common bacterial pathogens. They cause pneumonia, sinusitis, otitis media, and meningitis. Pneumococcal pneumoniae usually develop when mechanisms that normally expel inhaled organisms are impaired by viral infection, smoking, immobility, or other insults. When Streptococci pneumoniae reaches the alveoli, they proliferate, cause acute inflammation, and spread rapidly to involve one or more lobes. Alveoli filled with proteinaceous fluid, neutrophils, and bacteria. Older adults have a higher rate of illness and death from pneumococcal pneumoniae, which can often be prevented by pneumococcal vaccine. Streptococcus pyogenes bacteria are often part of the normal flora of the skin and oropharynx that can become pathogenic in other body regions. The bacteria spread from person to person by direct contact with oral or respiratory secretions. They cause severe streptococci pharyngitis or strep throat, scarlet fever, and rheumatic fever. Endocarditis and glomerulonephritis may occur as a sequela following untreated or inadequately treated streptococci pharyngitis. Clindamycin cleocin is a lincosamide, a broad-spectrum antibiotic. These are bacteriostatic agents that block protein synthesis in bacteria by binding to the 50S subunit of the bacterial ribosome, which inhibits RNA-dependent protein synthesis. So here the dosage of the clindamycin PO drug. PO is between 150 to 450 milligram every 6 to 8 hours. And then I gave you the IV drug, which you probably won't be needing those numbers because you're dealing with outpatient. So inpatient would be 600 to 900 milligram IV every 8 hours. So clindamycin, we would normally give it inpatient when they are having surgery prophylactically. We would normally give cephalosporin, but like ANSAF, but when they are severely allergic, like anaphylactic reaction to penicillin, we would not give a cephalosporin. We would instead give clindamycin IV 900 milligram. So clindamycin has activity against staphylococci and streptococci as well as to anaerobes. These include B. fragilis, which is Bacteroides fragilis. Now, Bacteria fragilis is an anaerobic gram-negative rod-shaped bacteria that is part of our normal flora in the colon. So they have activity against B. fragilis. They also have excellent oral bioavailability, 90% of it, and it penetrates well into the bone and abscess cavities. So that's why they, are very good for people that are having surgical procedure if they are not allergic to, if the person's not allergic to the penicillin family or ANSAF, which cephalosporin family, because they tend to like to use ANSAF a lot in the surgery. So ANSAF actually is pretty good for orthopedics. It goes right into the bone as well, but not so much as abscess cavities. So Clinda is good for that. It has 90% bioavailability. It is also used for treatment of aspiration pneumonia and lung abscesses. So clindamycin has activity against most community-associated strains of MRSA and is used for skin and soft tissue infections caused by this organism. Clinda may be used as a second agent in combination therapy for invasive streptococcal and clostridial infections to decrease toxin production. So Clinda is the drug of choice for several group A streptococci infection and for gas gangrene infections caused by clostridial perfringens. So the clostridial perfringens are gram-positive rods that are anaerobic, and they form spores found in nature and also in our colon. They're found there. They tend to cause like food poisoning, severe diarrhea, to necrotizing enterocolitis and myonecrosis. So also we can use Clinda for treatment of suspected anaerobic infections of the head and neck. So if you have somebody has a peritonsillar or retropharyngeal abscess, necrotizing fasciitis, Clinda is good for that. The adverse effects of Clinda are nausea, abdominal pain, and LFT abnormalities. Liver function profile should be checked intermittently during extended therapy. Hypersensitivity reactions with prominent skin rash are common with clindamycin and as is the pseudomembranous colitis secondary to Clostridium difficile associated diarrhea. So it's very, very common with Clinda. So we tend to be very hesitant to use it. So if a person, for instance, have a rash or hives to penicillin drug, and we're going to give a beta-lactam drug, which is similar in the family of penicillin, like the cephalosporin, say for example ANSAF, 2 grams IV in the OR that I was going to give it. We want to make sure that the person did not have anaphylactic reaction to penicillin. Hives or rash, we would give it. That's very, very, very small chance, probably less than 1% of them even having a reaction when we give ANSAF. So we want to make sure that the person does not have anaphylactic reaction to that. Otherwise, they do have anaphylactic reaction, we would give Clinda. So, but Clinda has, this adverse effects that could cause the person to have C. diff. It's one of the biggest culprit of that. So we have to be careful. So this is the most severe toxicity of clindamycin. It is actually life-threatening, the pseudomembranous colitis secondary to Clostridium difficile, so C. diff. The cause is superficial infection of the bowel with C. diff an anaerobic gram-positive bacillus. So Clostridium difficile associated diarrhea is characterized by profuse watery diarrhea up to about 10 to 20 watery stools per day, abdominal pain, fever, leukocytosis. Stools that often contain mucus and blood. Patient should be taught to promptly report diarrhea if they are on clindamycin. If left untreated, the condition can be fatal. If C. diff is diagnosed, clindamycin should be discontinued immediately, and the drugs of choice to treat C. Clostridium difficile is vancomycin or metronidazole, which is Flagyl. So diarrhea usually ceases after about 3 to 5 days after starting vancomycin. Linezolid or Zyvox is a broad-spectrum oxazolidine antibiotic. It comes in a couple of formulations, IV and oral, 600 milligram IV or PO every 12 hours. Linezolid is a bacteriostatic inhibitor of protein synthesis. The drug binds to the 23S portion of the 50S ribosomal subunit and thereby blocks formation of the initiation complex. It is potent in activity against gram-positive bacteria, including drug-resistant enterococci, staphylococcus, and streptococci, but not against the enterobacteriase. Linezolid is useful for serious infections with VRE as an alternative to Vanco, which is actually the drug of choice. But if they're allergic to Vanco, then they can have Linezolid for the treatment of MRSA infection in patients, obviously intolerant of vancomycin therapy and oral therapy of MRSA infection when IV access is unavailable. So if there's no IV access, then you'll resort to Linezolid. Linezolid should generally be avoided for catheter-related bloodstream or catheter site infections. Resistance can develop to this antibiotic, and it is imperative that organism susceptibility is verified. So always look to your region as to what is resistant so you don't use it on patients. Adverse effects of Linezolid. Usually they're well tolerated but can cause diarrhea, nausea, and headaches. Linezolid oral suspension contains phenylalanine and hence should not be used in patients with phenylketonuria. So phenylketonuria actually is an autosomal recessive inherited metabolic disorder that is treated with phenylalanine restricted diet, as these patients have a mutation in the phenylalanine hydroxylase gene, which helps them convert phenylalanine to tyrosine. So linezolid can cause reversible myelosuspension, manifestation as anemia, leukopenia, thrombocytopenia, or even pancytopenia. Risk is related to duration of use. Complete blood count should be done weekly. Special caution is needed in patients with pre-existing myelosuppression, those taking other myelosuppressive drugs, and those that are receiving Linezolid for more than 2 weeks. If existing myelosuppression worsens or new myelosuppressions develop, discontinue Linezolid should be considered. So let's talk about tetracyclines. These tetracyclines are bacteriostatic antibiotics that bind to 30S ribosomal subunit and blocks protein synthesis. These agents have unique roles in the treatment of rickettsia, chlamydia, and mycoplasma infections. They are also used as therapy for most tick-borne infections and Lyme disease-related arthritis. They can be used as an alternate therapy for syphilis and therapy for multisida infections if the person is penicillin allergic. So what is this multisida, P. multisida? So it is Pasteurella multisida is a common cause of infection followed by bites or scratches caused by a dog or a cat. A person may develop cellulitis at the site of injury. Drug of choice would normally be prophylactically used, would be augmentin, which is amoxicillin and clavulanet. They are two drugs in one pill, and the dose would be somewhere from 875 milligram of amoxicillin and 12 milligram of clavulanet, given every 12 hours up to 3 to 5 days. So it's one pill combination of these two drugs. And if the person was allergic to penicillin, then of course we would resort to alternative usage. So we would use doxycycline. We can use Bactrim, which is trimethoprim sulfamethoxazole. We can use Cipro or levofloxacin. So minocycline and doxycycline also have activity against some multi-drug resistant gram-negative pathogens and may be used in this setting based on results of susceptibility testing. So tetracycline comes in 250 milligram to 500 milligram PO every 6 hours. It is commonly used in severe acne, and in some times it's used in H. pylori eradication. That's Helicobacter. That H stands for Helicobacter pylori eradication regimens. It has been largely replaced by doxycycline for other infections. Aluminum and magnesium containing antacids and preparations that contain oral calcium, oral iron, or other cations can significantly impair oral absorption of tetracycline and should be avoided within 2 hours of each dose. Doxycycline comes in a couple of formulations, PO and IV, 100 milligram every 12 hours. This is the most used tetracycline and is standard therapy for C. trachomotis, Rocky Mountain spotted fever, elarochlorosis, and psittacosis. This agent also has a role for malaria prophylaxis and for treatment of community-acquired pneumonia. It is also used for uncomplicated skin and skin structure infections caused by community-associated MRSA. Now, minocycline comes also in a couple of formulation, IV and PO. You can start off with 200 milligram and then move on to 100 milligram IV or PO every 12 hours. So minocycline is like doxycycline in its spectrum of activity and clinical indications. Among the tetracyclines, minocycline is most likely to provide coverage against Acinetobacter. Minocycline can also be used to treat pulmonary nocardosis, cervicofacial acintomycosis, and sternotrachomonas maltophilia infections. Adverse effects of tetracyclines are nausea and photosensitivity. These are common side effects, so patients should be warned about direct sun exposure. Rarely these medications are associated with pseudotumor cerebri. They should not be routinely used for patients under 8 years of age or to pregnant or lactating women because they can cause tooth enamel in the developing fetus and young children. Minocycline is associated with vestibular disturbances. Oral formulation of tetracycline may cause esophageal ulceration if not properly swallowed. Sulfonamides and trimethoprim. Sulfamethoxazole and trimethoprim slowly kill bacteria by inhibiting folic acid metabolism. This class of antibiotics is most used for uncomplicated UTIs, sinusitis, and otitis media. Some sulfonamide-containing agents also have a unique role in the treatment of P. geovese, nocardia, toxoplasma, and sternotrachomonas infections. Trimethoprim 100 mg PO every 12 hours is occasionally used as a monotherapy for treatment of UTIs. Trimethoprim sulfamethoxazole, that's Bactrim, is a combination of antibiotic. Comes in IV or PO with a ratio of 1 to 5 of trimethoprim to sulfamethoxazole. The preparation IV is dosed at 5 mg per kilogram IV every 8 hours for serious infections. The oral preparation comes in 160 mg of trimethoprim and 800 mg of sulfamethoxazole combined in a drug. This is a double-strength tablet that are extensively bioavailable with similar drug concentration obtained with IV and PO formulations. The combination has a broad spectrum of activity but does not inhibit P. geonosa anaerobes or group A streptococci. It is a therapy of choice for P. geovese pneumonia, sternotrachomonas maltophilia, Troherma whippley, and nocardia infections. It is commonly used for treating sinusitis, otitis media, bronchitis, prostatitis, and UTIs. So UTI, one double-strength tablet PO, Q 12 hours. So trimethoprim and sulfamethoxazole is active against MRSA and is widely used for uncomplicated cases of skin and soft tissue infections caused by this organism. So they often use like 2 double-strength tablets PO every 12 hours. It is used as P. geovese pneumonia prophylaxis, so basically like 1 double-strength tablet PO twice a week, 3 times a week, or single strength or double strength daily. In HIV infected patients, solid organ transplant patients, and bone marrow transplant patients, and in patients receiving fludarabine IV therapy is routinely converted to PO equivalent for patients who require prolonged therapy. For serious infections such as nocardia, brain abscesses, drug levels should be monitored with sulfamethoxazole peak between 100 to 150 mics per ml and TRA between 50 to 100 mics per ml and dose adjusted accordingly. In patients with renal insufficiency, doses can be adjusted by the following trimethoprim peaks, somewhere from 5 to 10 mics per ml. Prolonged therapy can cause bone marrow suppression, possibly requiring treatment with leucovorin, which is like about 5 to 10 milligram PO every 24 hours until cell counts normalize. Adverse effects of Bactrim. These drugs are associated with cholestatic jaundice, bone marrow suppression, hyperkalemia, especially with the trimethoprim and sulfamethoxazole, interstitial nephritis, there's a false elevation in serum creatinine and severe hypersensitivity reactions like Stevens-Johnson syndrome and erythema multiforme. Nausea is common with higher doses. All patients should be asked whether they are allergic to sulfa drugs, and specific commercial names should be mentioned, example Bactrim or Spectra. Hemolysis in the setting of glucose 6-phosphate dehydrogenase or G6PD deficiency may also occur. Beta-lactam antibiotics derive their name from the beta-lactam ring that is part of their chemical structure. An intact beta-lactam ring is essential for the antibacterial activity of these drugs. Several gram-positive and gram-negative bacteria produce beta-lactamases, which are enzymes that disrupt the beta-lactam ring and inactivate the beta-lactam antibacterial drugs. This is the major mechanism by which microorganisms acquire resistance to these drugs. Although a beta-lactam ring is common to all beta-lactam antibiotics, the characteristics of these drugs vary widely because of differences in their chemical structure. Because of these differences, the range of activity to bacteria is also different. So beta-lactams include penicillins, cephalosporins, carbapenems, and monobactams. Penicillins interfere with the synthesis of the cell walls by irreversibly binding to the penicillin-binding proteins in the bacterial cell wall, causing osmotic rupture and death. This is known as bactericidal. Penicillins are effective against gram-positive bacteria that have an exposed peptoglycan cell wall. Because mammalian cells do not have a cell wall, penicillin has no direct effect on the cells of the human host. These drugs are effective and safe, and they are most prescribed antibiotics. Penicillins remain the drug of choice for syphilis and infections caused by penicillin-sensitive streptococci, methicillin-sensitive Staphylococcus aureus, Listeria monocytogenes, Pasteurella multocida, and Actinomyces. Here's a picture of the difference between the gram-positive versus gram-negative organisms. So all bacteria are surrounded by a cell envelope. They are either gram-negative or gram-positive organisms. But the gram-positive cell walls are structurally simple, containing a thick layer of peptidoglycan with embedded tectoic acid external to the plasma membrane. And then the gram-negative cell walls are structurally more complex, containing three layers of a thin, actually three thin layers of peptoglycodecan and outer membrane containing the lipopolysaccharides. So the gram-negative organism cell envelope has three layers: the cytoplasmic membrane, a thin cell wall, and an outer cell membrane, making it hard to penetrate. However, penicillin can cross it to reach the penicillin binding proteins to disrupt the cell wall of the bacteria and cause rupture and death to the bacteria. And then the gram-positive organism cell envelopes have two layers: the cytoplasmic membrane and a thick cell wall. Despite its thickness, penicillins can actually penetrate the cell wall to gain access to the penicillin binding proteins to disrupt the cell wall. of the bacteria and cause rupture and death to the bacteria. Penicillins, we're going to talk about penicillin VK, comes in a PO drug, 250 to 500 every 6 hours. It is a narrow spectrum antibiotic against gram-positive and a few of the gram-negative bacteria. So penicillin VK is stable in an acidic environment, allowing it to be administered orally. Injectable form is also available. The oral formulation may take about 1 hour before or 2 hours after a meal to enhance absorption. It is used to treat group A streptococcal pharyngitis, tonsillectomy, and scarlet fever. It is the drug of choice for prophylaxis against rheumatic fever. Diclosilin, given every 6 hours. The dose is between 125 to 500 milligram. It is a narrow spectrum penicillinase-resistant penicillin used for the treatment of soft tissue infections caused by penicillinase producing staphylococci and has demonstrated the susceptibility to the drug. Amoxicillin, another narrow spectrum antibiotic, so it comes in the extended release formulation as well, and it is used for uncomplicated sinusitis, pharyngitis, otitis media, community acquired pneumonia, and UTIs. It is a broad spectrum amino penicillin. Cephalosporins, these are narrow spectrum antibiotics, and they actually increase with the gram negative spectrum. So the higher the number, the more negative spectrum they get. These exert their bactericidal effects by interfering with cell wall synthesis by the same mechanism as penicillins. Cephalosporins contain a beta-lactam ring that is primarily responsible for their antimicrobial activity. There are 5 generations of cephalosporins. These agents are clinically useful because of their broad spectrum of activity and low toxicity profile, accounting for use sometimes to treat respiratory tract infections, skin infections, endocarditis prevention, meningitis, gonorrhea, and some gastrointestinal illnesses. All cephalosporins are devoid of clinically significant activity against enterococci when used alone. Within this class, only ceftaroline is active against methicillin-resistant Staphylococcus aureus, MRSA. Ceftaroline, or the other name for it is Teflaro, 600 milligram IV every 12 hours, is the only 5th generation cephalosporin with an anti-MRSA activity, and that is USDA Food Administration approved for acute bacterial skin and skin structure infections and community-acquired bacterial pneumonia. Ceftaroline has MRSA activity and is active, and its activity is equivalent to vancomycin for the treatment of severe respiratory infections. First generation cephalosporin have activity against staphylococci, streptococci, E. coli, and many Klebsiella and Proteus species. These agents have limited activity against other enteric gram-negative bacilli and anaerobes. Cefazolin 1 to 2 gram IV or IM every 8 hours is the most used parenteral preparation, and cephaloxin or Keflax, which comes in 250 to 500 milligram PO every 6 hours, and cefadroxil 500 milligram to 1 gram PO every 12 hours are the oral preparations. So in the OR, we would give ANSEF, which is the first generation um, cephalosporin. This is given for prophylactic surgical procedures. Orthopedics, they actually love it. I think I mentioned it earlier. They love it because it's very effective. They reach the bone. This medication actually reaches the bone, so that's why orthopedics love it so much. And then we have the PO form, okay, of the first generation, the cephaloxin or Keflex. Okay, so don't get them mixed up. ANSEF only comes in IV form, all right? So don't get them mixed up. Then these agents are commonly used for treating skin and soft tissue infections, UTIs, MRSA infections, and for surgical prophylaxis, like I mentioned before. It's IV, and it's the other name for ANSEF is cefazolin. So cefazolin, okay? So if someone's planning to have a cesarean section or something, you would use prophylactic ANSEF 2 grams IV, and the other name is cefazolin 2 grams IV. It's mostly weight-based also. So if someone that's really morbidly obese with a BMI of, you know, 35 or something like that, we probably give 3 grams instead of 2 grams. So these drugs should not be used in the treatment of respiratory infections because they are not very active against H. influenzae, even though it is said it is active against H. influenzae, as it is generally resistant. Cephaloxin or Keflex, these are the PO drugs I'm talking about now, are active against streptococci such as Streptococcus pyogenes, Staphylococcus aureus, P. mirabilis, Klebsiella pneumoniae, and Moraxella catarrhalis. So this cefadroxil is active actually against streptococci such as Streptococcus pyogenes, Staphylococci, E. coli, P. mirabilis, and Klebsiella. So the first generation cephalosporin should not be prescribed for serious systemic infections because of their limited spectrum of activity. Each generation of cephalosporins have a broader spectrum of activity against aerobic gram-negative bacteria, but each generation also have less activity against gram-positive bacteria. Collectively, these agents have limited activity against anaerobes. Adverse effects of cephalosporins. All cephalosporins have been rarely associated with anaphylaxis, interstitial nephritis, elevated liver function tests, anemia, and leukopenia. Penicillin allergic patients have up to 0.4% to 7% incidence of cross-hypersensitivity reaction to cephalosporins. These agents should not be used in patients with a reported severe penicillin allergy, that is, anaphylaxis, without prior skin testing or desensitization, or both. Prolonged therapy that is greater than 2 weeks is typically monitored with a weekly serum creatinine and CBC. Because of its biliary elimination, ceftriaxone may cause biliary sludging. Cefepime has been associated with CNS side effects, including delirium and seizures. This is a diagram of several classes of antibacterial compounds that are typically classified based on their bacterial target. So as you can see, we were just talking about the cell wall disruption by the beta lactams, and then we talked about the glycopeptides, that's the vancomycin, and here we talked about the ribosomal disruption here, the 30S subunits by tetracycline, aminoglycosides. Now, these are gentamicin, tobramycin. You probably won't see it being given outpatient. It's mostly given intravenous. So, and then the 50S subunit macrolides. That's in the family. Family that has azithromycin, clarithromycin, erythromycin. So that's macrolide, and then they interfere with the ribosomal subunit 50. And then down here below we have the metabolic pathway that they interfere, um, that prevents the folic acid from being used by the bacteria to build themselves so they can proliferate. So that interferes with the folic acid synthesis of the bacteria. We have the sulfonamides, trimethoprim, and down below here, ionized works in another way that interferes with the mycolytic acid synthesis. So again, the metabolic pathway is disrupted. The ionized is actually used for someone who has been diagnosed PPD positive, you know, that has been exposed to someone with TB. So they're positive results. So they're given as a prophylactic drug, ionized. You'll be checking the liver function for that when the patient's on the ionized. And then you have the DNA synthesis here that they interfere with, the the fluoroquinolines, which is ciprofloxacin, levofloxacin, moxifloxacin, and then they have the interfere with the RNA synthesis, which is rifampin. Will do that. Okay. So here we go. So we're back to the case study that we were talking about earlier. Since I went a little bit off topic, talking about individual families of the antibiotics. So here we're going to talk about the penicillin allergy. For mild purulent SSTI, all the empiric antibiotic choices listed above would be considered appropriate for penicillin allergic patients. Mild non-purulent SSTIs in patients with a non-immediate or no anaphylactic penicillin allergy, cephalexin may be the first alternative. In cases of true penicillin allergy that's immediate or anaphylaxis, clindamycin is recommended. So clindamycin, 300 to 450 milligram PO 3 times a day or 4 times a day, and the doses that are greater than 450 for the entire day would often not be tolerated by patients. It will cause them to be sick and vomit. Organism-specific antimicrobial selection, Streptococcus pyogenes, mild infection, you probably use penicillin VK, given PO 250 milligram to 500 4 times a day, or amoxicillin 500 PO 3 times a day. The methicillin sensitive S. aureus MSSA, if it's mild infection, we probably give diclosilin 250 to 500 milligram PO QID, cephalexin 500 milligram PO TID or QID. And if it's MRSA, mild infection, we can give either of these. So trimethoprim sulfamethoxazole, which is Bactrim, 1 to 2 double strength tablets, POBID, doxycycline 100 milligram, POBID, minocycline 100 milligram, POBID, linezolid 600 milligram, POBID. But linezolid is a very expensive option. Okay, so we try to keep in mind when we are prescribing patients drugs, we want to give them something that will do the job, but in a cheap way. Okay, so you want to get in the most expensive. You don't want to get to the most expensive. You want to try something that is reasonable cost, that the patient can afford. So, and then we'll move on to clindamycin, 300 milligram to 450 milligram PO, 3 times a day or 4 times a day. Again, so anything more than 450 milligram a day would cause the patient to be sick to the stomach, and they won't be compliant with their drugs if they are sick. So MRSA strains have demonstrated increasing resistance to clindamycin. So you have to check again your locality, what the resistance are to which antibiotics. So you tend not to give that because of the resistance in your region. Okay. So in all cases, culture and susceptibility results should be followed up on, and antibiotic therapy should be tailored to these results. So you want to narrow the culprit down. In Jimmy's case, we would not have any suspicion for anaerobic organisms, but these are included here to make the discussion complete. In cases where anaerobics are thought to be potential causative pathogens, antibiotic classes listed have good anaerobic activity, such as metronidazole or clindamycin. What antimicrobial agent or agents, dosage form, dose, schedule, and duration of therapy are best for this patient? According to the Infectious Disease Society of America guidelines for the treatment of soft and skin tissue infections and MRSA, Jimmy would be an ideal progression of his infection or some precursor signs of systemic manifestation that could warrant the addition of antibiotics. If antibiotics were added after the IND, then the choices would be Bactrim trimethoprim sulfamethoxazole 1 to 2 double strength tablets, POBID, or doxycycline 100 milligram POBID, minocycline 100 milligram POBID, linezolid 600 milligram POBID, but just keep in mind that this drug is more expensive. Clindamycin 300 to 450 milligram POTID or QID. But then, of course, Jimmy was non-compliant due to he had nausea and vomiting with this medication. Treatment duration for mild purulent SSTI, as in Jimmy's case, 5-day duration is the minimum, but treatment can be extended if the SSTI has not improved by the 5th day. So 5 to 10 days pending clinical response. Was drainage or IND alone an appropriate management strategy for the initial presentation of this case? Surgical IND or a debridement is considered the standard of care for any large focal area of fluid collection on the skin, such as furuncles and carbuncles. They are often called boils. At Jimmy's first presentation to the urgent care, IND alone was a reasonable treatment option. Now that Jimmy is returning with a recurrent purulent SSTI, despite IND, antibiotics in addition to a repeated IND are warranted. Based on the above information, the patient has failed oral clindamycin and an initial IND. Does this patient need antibiotic treatment in addition to the second IND? And if so, what antimicrobial regimen would you now recommend for this patient? So be specific with the dosage, schedule, and duration of the therapy. Antibiotic therapy, in addition to a repeat IND, is recommended after lack of response to an initial IND alone. Other criteria also warrant the addition of antibiotic therapy after IND. The Infectious Disease Society of America guidelines for this soft tissue and skin infection and MRSA recommend antibiotic therapy in addition to IND when the following conditions are present: severe or extensive disease, multi-sites, or rapid progression in the presence of associated SSTI, presence of systemic signs and symptoms, presence of immunosuppressive comorbidities or medications, extremes of age, multiple abscesses or those in difficult area to drain, associated septic phlebitis, lack of response to IND alone. Jimmy's infection could arguably be considered progressive, but his continued infection has not been adequately treated due to non-compliance with clindamycin, and he has not had surgical intervention until his presentation to the urgent care. He also displays some precursor systemic signs and symptoms of infection, but again, his infection is just being adequately treated for the first time in the urgent care, and he is otherwise clinically stable. Acceptable antibiotics should target MRSA, and any of the following would be acceptable. However, Bactrim has routinely been the most active antibiotic to date. Trimethoprim sulfamethoxazole 1 to 2 double-strength tablets PO twice a day. Doxycycline 100 mg PO twice a day. Clindamycin 300 to 450 PO 3 times a day to 4 times a day, although this would not have been given in this case study since the patient has intolerance to this drug. Linezolid 600 mg PO twice a day. In all cases, culture and susceptibility results should be followed upon, and antibiotic therapy should be tailored to these results. In the process of this, follow-up is often sporadic, and practitioners can aid in making sure patients get the most appropriate antibiotic therapy based upon culture and susceptibility results. Treatment duration: mild or possibly moderate purulent or recurrent SSTI for this patient case study. 5 to 10 days pending clinical response. What decolonization measures could be considered for Jimmy if his nares and/or groin cultures are positive for MRSA? Decolonization of everyone is impractical and not recommended. However, decolonization of selected patients with recurrent MRSA infections or a closely defined group of patients, such as household contacts or athletic teams, may be of value. Strategies to decolonize patients have ranged from topical methods to the use of systemic antibiotics. Each modality has its own pros and cons, but all have been associated with reducing the recurrence of MRSA infections in some manner. The most employed method consists of two therapies. One is the topical mupirocin, or the other name is Bactroban, locally placed in the nares. And the second option is chlorhexidine, 4% scrub to the entire body. While only mupirocin is FDA indicated for MRSA decolonization, the use of both modalities have been the most successful at reducing MRSA recurrence or infections. Other methods have been utilized successfully, but the use of mupirocin to the nares and chlorhexidine scrubs to the entire body is the consensus recommendation from an expert panel for recurrent infections or close contact outbreaks. Mupirocin ointment to the nares would be the best agent for the decolonizing a patient with a positive nasal swab. However, this alone has been associated with failure because MRSA does not solely colonize the nares. Likewise, the use of only the chlorhexidine scrub for any non-nares swab cultures, groin in this case, would not be considered optimal, given that up to 30% of the patient may have MRSA colonization of their nares. Given the propensity for MRSA to colonize many distinct body sites, a multifaceted approach to decolonization makes the most sense for patients with recurrent infections or close contact outbreaks, even if only one swab culture is positive. What clinical and laboratory parameters are necessary to evaluate the therapy for its effectiveness in treating this patient's SSTI? Monitor for decreased pain, inflammation, and redness in right gluteal area, as well as the ability to perform ADLs such as attending class. Monitoring patient report symptoms would be appropriate. Provide the patient with a thermometer to aid in discerning a febrile episode. So they're supposed to keep a detailed diary if there are any recurrent episodes. Check culture and sensitivity results so that empiric antibiotics can be tailored to the organism or organisms causing the infection. It is likely that any of the 4 primary agents, such as Bactrim, doxycycline, minocycline, or linezolid, should be active in MRSA cases. Clindamycin would not be used in Jimmy's case. Initiate proper wound care and dressing changes as needed, and take adequate measures to keep the wound area covered and protected until the skin is fully healed and intact. The follow-up should be considered. This could be done through the Student Health Center or an FNP appointment. Instruct the patient to keep the wound dry and sterile using local wound care as prescribed. To wash hands before changing the bandages twice a day. Instruct to take the prescribed Bactrim 1 double-strength tablet twice a day. The key to this therapy is to take it at the same time each day, and it is important to not miss doses. The patient should drink plenty of water while on this medication and throughout the day. The patient should wear protective sunscreen with at least SPF of 30 or greater, as this medication can make him more susceptible to sunburns. It is important to take the proper steps to reduce skin colonization and nose colonization with MRSA. Apply the prescribed nasal Bactroban with a Q-tip into each nostril twice daily for 5 days. Recommend bathing with a chlorhexidine scrub or HIPAA at least 3 times per week until the scrub is gone. Measures to ensure his living condition are decolonized: washing all sheets, bed linens, towels, and clothing in a hot cycle of greater than 120 degrees Fahrenheit before using again. Disinfect all surfaces in the room, bathroom, shower, doorknobs, phones, remote controls, areas that are commonly touched. And this ends our skin and soft tissue infection case study. Thank you very much for listening.